two talks. John McDonald is newly arrived as a faculty member at Johns Hopkins Hospital and Johns Hopkins University. And we're very lucky to have him in Baltimore and also here today. And he'll talk about stem cells and spinal cord injury. I will then talk about some data on stem cells as well, specifically motor neurons in the spinal cord. I can also then summarize the immunology section of the science talk that we had if people are still interested. If people are too exhausted, I don't have to do that, so we'll take a show of hands at that point. John?
Well, thank you very much, Doug, and thank you very much for inviting me. It's really a pleasure to be here today. So I'm going to talk about stem cells, but I'm going to talk about an approach where we can mobilize the endogenous stem cells. So I do a lot of work similar to what Doug does with transplantation of embryonic stem cells, but I want to leave that to him and focus on the endogenous system. So what can we do to optimize the body's own ability to self-repair now that we're in this arena where we believe the system can do a much better job than we ever thought possible before? So this was the center in Washington University that I'm leaving. It was all the spinal cord injury research occurred on the 4th floor, and all the rehabilitative care occurred here on the 3rd floor. And that was really a key thing. The crosstalk between the clinics and the laboratories is essential, and I think you'll see that from this talk. So here's what I'd like to cover: the problem of spinal cord injury, keeping in mind that the problem is similar amongst neurologic diseases, whether it be transverse myelitis or traumatic injury. The approach to repair is similar, despite the causes being different. The importance of crossing barriers between the clinics and the labs, putting them together is one important way to make that happen. We'll review the different leading approaches that scientists are taking towards repair of the nervous system, and then focus on ranking them in terms of their doability. So which of the strategies are most doable, which are the strategies that are predictably the most difficult, all right? And then which are those strategies that have combined benefits, that is, can both restore function and physical benefits. And then let's spend a bit of time challenging the implicit assumptions in our field, which are many. So is a substantial and delayed recovery of function possible? And then I want to emphasize the importance of examining outliers. You know, the variability both in the patients we see and the data that we get from our laboratories is critical. It is that variability that teaches us the most. So what's in common with that subgroup of individuals who has the miracle recovery after a spinal cord injury? So this is the problem spinal cord injury. The soft tissues get damaged from the bony fragments, and your result is an injury much like this. This is a T2-weighted MRI image. The head would be up here, eyes in this direction. This is the anterior part of the neck. This is the back of the neck. And this dark structure here is the spinal cord. The white is the CSF fluid that bathes the spinal cord. This is an individual who had a C4-5 level injury some 20-odd years ago. And you can see there's a white cyst in the middle, so a fluid-filled hole. This is very typical that the injury will result in damage selectively at one level. The cord above that is relatively normal, and the cord below that's normal, and these are really important features. If you cut a cross-section through here, it looks like this. And the key is the spinal cord always dies from the inside out, whether it be transverse myelitis or trauma. And the reason for that is it rapidly swells inside a fixed bony canal. Once the pressure overcomes venous blood flow, you end up with a venous infarct or stroke. That causes the inside of the cord to die, so this inner dotted line outlines the cyst of the syrinx. This outer continuous line outlines the outer circumference of the cord. So everyone's left with some variable donut-like rim of tissue. And the key is this outer white matter is what carries the connections to and from the body. The inner gray matter houses those motor neurons that selectively go out at that level. So this is an individual, of course, who was completely paralyzed, ASIA, for the first 3 months. They would go home completely paralyzed and completely unable to feel below the level of the injury. And the real question is, what is this person capable of doing today? You know, the average answer would be that they'd still be paralyzed and have sensory dysfunction. Well, this is a person who can do Ironman and triathlons. So what does this teach us? It teaches us we don't need to cure the nervous system. We don't even need to come close. We just need to partially repair. In fact, this is sufficient to have a nearly normal person. Segmental loss of gray matter here is pretty much inconsequential. And the goal is all you need is enough connections down to the distal spinal cord where there are pattern generators pre-built in that are still completely intact, and you can harness the potential of those systems. This is a DTI-weighted image in the same spinal cord. And you can see the blue basically indicates the number of axons or connections going up and down the cord. And you can see there's pretty normal numbers up here, and then it rapidly drops off. In fact, there's only really axons at the edge, probably less than 10%. And this is very similar to what we see in animal models, where you need less than 10 to 15% of the connections to restore near normal function. So this makes our task much more doable. Now, of course, as you all realize, the usual prognosis for someone who comes in ASIA A or complete after a spinal cord injury is quite poor. The data say that fewer than 3% ever recover that miracle of walking. Only 10% regain enough function to be reclassified as incomplete or ASIA B, C, or D. Now, almost everyone has some recovery, and this has been traditionally assumed to be due to repair of the peripheral nerve damage that occurs at that level, but it may likely be due to other things. Most of that recovery typically occurs in the first few months and typically the first 6 months. Very few people ever have any substantial recovery of function more than a year or two out from an injury. And if they do, it's typically that they have some recovery early. So this data certainly is real, but it's no longer true. So what are the goals for restoration therapy? It's really critical to understand. We went over this, that a cure is not required. The goal is partial repair. Also, that partial repair produces disproportionate return of function. So small anatomical gains can translate into large functional gains and quality of life gains. And of course, the most important goal is improvement in quality of life. You don't simply want to restore sensation or movement. You want to change an individual's life. Giving someone back sexual function or bladder or bowel function gives life-changing events. Restoring the ability to walk gives a much lesser change in their life. In the end, we all realize that multi-stage interventions are required. There's not going to be any single magic approach to accomplish this. We ultimately want to develop therapies that are applicable to most individuals, both that apply in the acute period and the chronic period. If we focus on acute treatments only, we're only going to be able to treat a very, very small percentage of the people affected out there. We want treatments that are equally effective in the chronic period. And then, they're difficult enough, we want to try to get combined benefits. What treatments can produce both physical and functional benefits? And then ultimately, we need to offer hope. In fact, there's no good reason to remove hope. No one can tell someone that they can't recover. They can, it's just not true. And a very important goal, particularly in spinal cord injury, is simply complications. Changing this can change someone's life. Individuals typically are afflicted with multiple infections, skin breakdown, spasticity or stiffness, pathologic bone fractures because of the severe advanced aging of the bones and osteoporosis, blood clots, severe pain, autonomic dysreflexia. 30% of people with spinal cord injury have to be readmitted to readmitted to a hospital every single year because of these complications. So this is not only something that dramatically affects their lives, but it has a large economic cost associated with it. So simply changing these can change someone's quality of life. Now, we're going to be ranking in terms of doability the different treatments, and we'll be going through those in just a little bit. And then I want to show you this ranking compared to which of those treatments can produce both physical and functional benefits. So ultimately, we want to focus on treatments that fall into this category because they'll provide the greatest benefits. They'll be the most practical treatments. We'll be able to demonstrate their cost effectiveness, their ability to save money, and demonstrate a system that the payers will be willing to pay. So this slide depicts, in a schematic form, the different approaches that scientists are taking to overcome these problems. So one barrier is a physical barrier. The hole in the middle of the cord represents a zone that new axons cannot grow across. So a traditional approach has been to try to bridge this gap. So transplanting cells are cellular materials that are able to fill this up and be conducive to axonal growth from the broken connections here. So scientists have made quite a bit of progress in this arena. Active strategies today include transplanting Schwann cells and autologous transplants of olfactory and sheathing glia. These are cells that don't normally belong in the spinal cord, but they're cells thought to have special properties and conducive to regrowth. Now, we've gotten very good at getting these broken connections to grow into those growth supportive surfaces, but we're not good at getting them to grow out yet, so we still have a ways to go. Another barrier is that there's a scar around this zone that actively inhibits regrowth. It turns out that these broken connections are continually trying to regrow throughout the life of the individual. But they're constantly encountering signals that say stop, turn around. So one set of signals are usually used as directional cues during development, such as no-go and other factors. And it's like re-expressing or changing all the signs on the highway so they don't make any sense. There's another set of inhibitory molecules, such as MAG and chondroitin sulfates, that also actively inhibit regrowth. And scientists are taking approaches where they can add enzymes that can destroy those, or they can mask these inhibitors. And they've demonstrated substantially better regrowth under those conditions. But again, it's very limited regrowth both in quantity and magnitude. Another problem is that there are these broken connections, and we can add growth factors and activate the cells using cyclic AMP and other factors to help shift the balance from negative to positive and get better regrowth. But again, targeting that growth and selecting that growth is still a problem. Now, there are connections that exist across the lesion that are anatomically intact, but we're not taking advantage of its function because of the dysmyelination and improper myelination. So one approach is adding drugs that block the potassium and sodium channels, such as HP-184 and 4-aminopyridine. These are drugs that when you take it, they can allow this conduction block to be relieved, and the electricity can get across and function can be repaired. In addition, we can stimulate cells, oligodendrocytes, to remyelinate these zones, or we can transplant cells such as Schwann cells to enhance remyelination. So there's multiple strategies that make that quite doable, and that's been demonstrated in many laboratories. So the next slide is my version of ranking these strategies, because predictably there's some strategies that are much more doable, other strategies that are much more difficult. This is what I like to indicate as the red zone, that zone that hasn't been accomplished in any animal model, and we certainly can't accomplish in a human being. That is, we can't get the long tracts to regrow all the way across the lesion and then make the appropriate connections. We're making progress, but it's going to take a while to accomplish that goal. On the other hand, modulating the immune response, remyelination, breaking down inhibitors is much more on the doable end. A lot of progress has been made. These are simple strategies. It tries to take advantage of spontaneous regeneration. Birth of new cells and taking advantage of the endogenous progenitors is also a middle road doable strategy. But perhaps one of the simplest strategies is simply taking advantage of what the body's already trying to do in self-repair. We used to believe that the capacity of the adult mammalian nervous system was limited, and that regeneration really wasn't possible. We now understand that it's simply that the equation is much more complex, and there's a series of critical factors that require optimization. And I'm going to suggest that pattern neural activity is one of those, and I'll give you the background for that. So now if we take these strategies, rank them in terms of doability on this axis, this strategy being the most doable, likewise, the strategies at this end being the most difficult, and then also rank those against strategies that are capable of restoring physical integrity, because those are also important goals, it becomes quite easy to pick out the strategies that stick out. So this particular strategy is not only doable, but it's capable of restoring physical integrity function and therefore reducing complications. So I'm proposing to focus on these types of strategies, because they fall into this zone that will be able to create an environment that will be able to facilitate payment. If we can't pay for this treatment, it will never become a treatment. So this is one of these strategies. Now, it's quite difficult to get these little guys to do this. You spend a long time training them, and they walk off with the towels. But this is a California mouse, so he only goes for about 5 minutes, and he'll stop. But literally, there's been a lot of interest in partial weight-supported walking. And scientifically, it's added a great deal of insight into mechanisms of retraining and regeneration. But it's difficult to imagine this ever becoming a doable treatment, simply because it requires someone to come down to a center, and it requires an insufficient amount of time to do this. Basically, after someone reintegrates into life and has a job and a family, they don't have time to take off half a day to go down to a center, and many people don't even have access to that center. These types of treatments will never become treatments unless we change the paradigm and create a system of accessibility and doability. So here's a hypothesis that I'm going to put forth, that we need to optimize pattern activity in order to optimize spontaneous regeneration. Too little activity is not good, and this is the state that occurs after a spinal cord injury. because you're not getting signals from the brain and that you're not using the periphery to create sensory feedback. Also, too much signaling is not necessarily good, but for pragmatic reasons, it's difficult even to get onto this edge. Now, we don't know what's good activity, so what can we do? Well, we can use physiologic activity. We can try to activate some of the pattern generators. So what's the background to this? Where does this come from? Well, we know that optimal levels of pattern neural activity are absolutely required for most aspects of development. Okay? These cellular processes, new cell birth, neural cell survival, migration, fate choices, pathfinding, synapse elimination, and stabilization of circuitry, as well as myelination during development of the nervous system, requires pattern neural activity. If you disrupt pattern neural activity, you disrupt those processes. Those are the same processes we're asking to occur in regeneration. It's therefore very likely that they are also dependent on pattern neural activity. We know that pattern neural activity, and this has been shown in human studies as well as animals, that this activity is dramatically reduced after a spinal cord injury. In fact, imagine that perhaps we're even telling patients to reduce their activity, and perhaps we're not always doing the right thing and we're treating them with drugs that further reduce activity. What if we're inhibiting regeneration? Something we didn't think was even possible before. Well, we know that we can enhance neural activity in the cord through pattern feedback. So since we don't know what's good activity, let's use reciprocal movements of the legs, like walking, like riding a bike. Those will activate the pattern generator, produce a set pattern of activation throughout the cord, and that's been demonstrated by multiple groups. So this is one concept of how this can be accomplished in a human in a pragmatic way. We can take a functional electrical stimulation bike, take someone who's quadriplegic, put them on there. We can stimulate 3 muscle groups on each leg using a computerized system so that they ride this bicycle under their own muscle power. Now, normal physiology will tell you that if they do this with a sufficient load and for a sufficient amount of time, they're going to get cardiovascular training, they're going to build muscle mass, they'll even be able to build bone density. We know that from normal individuals. But it requires a sufficient load and duration. But people can be trained to do this. This can be put in people's homes. This is time efficient. So an hour of this will give them about 6,000 equivalents to steps. You know, an average person takes about 12,000 a day. So here's the idea again, that if we increase activity, and we can do this with functional electrical stimulation, the prediction is we should enhance regeneration. If we reduce activity with clinically relevant drugs, such as antispasmodic agents, such as baclofen, this model would predict that we would inhibit regeneration and perhaps recovery of function. These are testable hypotheses. So in animals, of course, we can do injuries, treat the animals with these interventions, and then measure regeneration. We can look at cell birth. We can look at migration of cells. We can look at myelination and formation of new circuits. So I'm going to share some early data that we have using both functional electrical stimulation as well as baclofen, and summarize this, demonstrating that FES can enhance regeneration, baclofen can dramatically inhibit regeneration, as well as recovery of function. And that this is not a new idea. There's plenty of data in the stroke literature and other areas suggesting that drugs that inhibit the nervous system can produce long-term impairments of recovery of function. So this is the FES paradigm. In this experiment, we completely transected the spinal cord. So the upper cord's not even connected to the lower cord, ensuring that the activity in the lower cord is maximally reduced. Then a month later, we implant a 2-channel FES device that's controlled across the skin. And it's set up to the peronealers in the back legs so that when it's turned on, they get alternating walking-like movements of the legs. And the goal was to do this 3 hours a day in 1-hour intervals, and compare it to a group that was treated identically, but the systems weren't activated. And this is the timeline. So we do the suction ablation injury, completely separating the cords in the mid-back. The animals are paralyzed and lose sensation below that level, lose bowel and bladder control. Implant the FES systems. And half of the animals activate that system for 3 hours a day, every day, and then have 2 groups. In this case, we're going to measure all the newly born stem cells that are being born in the cord. It turns out that over 200,000 new cells are born in the rat spinal cord every single hour. It's an amazing number. We can measure those cells being born, and then we can measure the number of those cells that survive using these 2 different groups. And basically, this is the data. This axis shows the level of the spinal cord from cervical level C2 down to lumbar L5. Now, the FES activity is restricted to the lower cord. The expectation is that we should enhance regeneration only in that lower segment of the cord, the upper cord being disconnected from the lower cord won't receive the increased activity, and you won't see the effect there. And that's exactly what we see. When you compare the two groups, experimental and sham are treated identically. They all have injury. They all have the FES implants. The only exception is the experimental group has them activated. When you compare levels above the level of the injury, C2 to T7, there's no significant difference between the blue and yellow bars. Just below the level of the injury at T11, there's also no difference. But there's a 70 to 80% enhancement of stem cell birth, and this translates into survival in the lumbar area of the cord, that area expected to receive the patterned activity from the FES activation. So this is really the first evidence to demonstrate that FES can actually be used to enhance one index of regeneration. We've now gone on to demonstrate that the same thing can affect axonal elongation, myelination, and differentiation of cells. We can shift cells into selectively creating neurons through FES activation. Likewise, if we do the same clinical paradigm, but now treat the animals with baclofen in relevant doses to that which humans take, we can show that there's really a dramatic reduction in the number of cells being born compared to the saline-treated group. And this translates into a huge loss of function. So the purple bar is a contusion-injured animal, and this is the spontaneous recovery that would normally be achieved from this moderate injury. Here's an animal treated with baclofen, and you can see a dramatic 6-point reduction on the BBB scale. Anyone who works with this BBB scale, 6 points are huge. It's 1/3 of the entire scale. This is an animal that walks well. This is an animal that can barely even use its hind limbs. Now, you can stop the treatment with baclofen, and this curve stays down. It's a permanent effect over a matter of weeks. It's not simply a sedation effect. You can't take this group, give them doses, and drop them down here. So it seems to be a selective effect. It generalizes to other drugs that also have inhibitory actions. The prediction also is that drugs like 4-aminopyridine and HP-184, which activate the nervous system, should stimulate regeneration and may be better treatments for spasticity. We also understand that baclofen in oral treatment is a very ineffective treatment for spasticity. Typically, patients will be at their maximal dose, and their spasticity will be just as bad. We can take the majority of patients off baclofen entirely without any ill side effects. So it's important not to stop baclofen immediately. Baclofen is often needed for certain things, particularly the baclofen pumps. Baclofen pumps deliver the drug directly to the spinal cord and not to the whole nervous system, which may be a much more beneficial way of achieving that. So I think baclofen is still a very important armamentarium treatment in our field, but more reserved for the baclofen pump as opposed to oral treatment. So what are the mechanisms? Well, we've been investigating the role of BDNF, cyclic AMP, and metalloproteases. We know that these are activated by activity. BDNF is released at synapses in an activity-dependent manner. BDNF elicits axonal and birth effects in combination with activity. It's blocked if you block activity. Cyclic AMP, there's been a lot of interest in this, is an intracellular messenger that's reduced after spinal cord injury, elevated with activity, and there's data to demonstrate that this is an important mechanism in this. Metalloprotease is also an enzyme very important for breaking down these inhibitory barriers. Enhanced release occurs with activity, which may be another mechanism accounting for this. So it's likely multifactorial, and we're in the process of determining the relative role of each of these. But we believe that activity is working through biological mechanisms very similar to the same drugs that we're trying to deliver through either genetic vectors or through pumps. But now we're doing it in I believe, the most effective way. We're using the body's own system to deliver it in a strategic manner right to where it belongs. So back to the idea that we need to optimize activity to optimize regeneration. We've been able to show that reducing activity reduces regeneration, increasing activity enhances regeneration. So after spinal cord injury, we're somewhere down here. Now how do we functionally move up in the case of a human being? It's a much more difficult task. And of course, it's difficult to measure regeneration in a human being. They're very unlikely to give up their cord. So let me show you some early compelling data. And this is what I mean by outliers. So we as clinicians examine patients, and there's certain patients that just things happen that should never happen. And this is one of these examples that demonstrates a substantial recovery of function can occur in a worst case scenario long after an injury. Okay, this individual happened to participate in our activity-based recovery program, but no conclusions can be drawn for that. The take-home message is simply that the highest level injury, the worst severity with no initial recovery, can recover multiple Asia grades more than 5 years out from their injury. So this individual was C2 Asia A, traumatic injury, occurred in 1995. There was virtually no recovery over the first 5 years, so remained unable to feel below the neck, unable to move below the neck, on a ventilator for those first 5 years. Accumulated all kinds of medical complications, and we'll walk through that. Began the activity recovery program in mid-1999. This is an example of the MRI. Again, this is the anterior part of the neck. The head's up here, the eyes are here. This is the spinal cord coming down. You can see that here's the level of the injury at C2. The cord's atrophied a little bit above and below, but here's a schematic diagram. There's still a small donut-like rim of tissue that remains at this level, shown here schematically. If we cut a section just a little bit lower, you can see that this donut-like rim of tissue is larger. If we do quantitative MRI, we can show that there's about 25% of the cord at that level. Now, MRI doesn't distinguish functional versus non-functional tissue, but suffice it to say that most people have a sufficient number of connections probably across the lesion. We need to take advantage of that. So we were able to place this in this individual's home. They were able to do this for an hour, 3 times a week against resistance, usually at a level of 2 or 3, which is sufficient to build bone density and muscle mass. So we already know from normal physiology that with activity and resistance that we can increase muscle mass, maintain bone density, and enhance blood flow. And perhaps these then can be used to decrease complications, such as pathologic bone fractures, skin breakdown, and blood clots. But what we're simultaneously and even more interested in looking at is, can we use activity programs to decrease spasticity? Can we use it to actually enhance regeneration and recovery of function? We have animal data that suggests we do, but what do we see in human beings? Now, this is an example of this individual's complications, and this is pretty typical for someone who's quadriplegic with no recovery on a ventilator. This individual was hospitalized for a half a year from middle of 1995 to 1996 and then discharged. Had a sacral skin ulcer, grade 4, that means all the way down to the bone. Involved osteomyelitis, took a year and a half to heal. Okay, that's packing it twice a day, can't sit on it, can't lay on it, that changes your life. Heterotopic ossification, this is where bone forms in soft tissues. It's a big problem in young males after an injury like this. Autonomic dysreflexia, requiring readmission to the hospital multiple times in the first year after discharge. Multiple blood clots in the large veins of the legs, requiring filter placement. A surgery is required to do this. Pathologic bone fracture requiring, again, surgery for internal stabilization. A collapsed lung requiring emergent bronchoscopy to save this individual's life, to remove the mucus plug. An ankle ulcer, again, that led to osteomyelitis. And actually, they contemplated amputation of this leg because this individual's never going to use this leg, and it's killing them. So it's not unheard of to do this. Well, they decided to keep the leg. They had plans for it. But it took a year and a half to heal. And still, there's problems with chronic osteomyelitis. Another sacral skin ulcer occurred in 1998. But what's an outlier for this individual is that all these complications virtually went away. So since then, there's only been one major medical complication, a pathologic bone fracture. Now, typically, this doesn't happen. And if it does happen, it's because the person dies. So what's going on? They kept amazing records. We were able to also assess the number of infections this individual had in the antibiotic treatment. If you look at the first 3 years post-discharge from the hospital, 1996 through 1998, 49 different infections requiring 527 total days of IV and oral antibiotics. This individual was sick most of the time. Couldn't hold a job, couldn't predictably show up for something, certainly couldn't travel. But if you look at the first 3 years following the implementation of the treatment program, 2000 to 2002, this changed to only 10 infections and 64 total days of antibiotics, a 10-fold reduction. Again, we need to take care in associating this with the treatment, but this changed this individual's life. Now this person could go on vacation with the family, could travel outside of the United States, could hold a job, could predictably say they're going to show up for something and then show up for that. This, just simply affecting this, can dramatically change someone's life. There's other things that shouldn't have happened. So we're able to reverse the severe loss of bone density, more than 4 standard deviations below normal. This puts them at high risk for pathologic bone fractures back into the normal range. This is simply not possible in the population of spinal cord injury, but it is. Combinations of pharmacological therapy plus physiology, that is, activity associated with resistance and load bearing on those legs, we know from normal physiology is sufficient to reverse this. We're also able to reverse muscle mass in the legs and the buttocks from way below normal back into the normal range. And why is this important? It's important simply from a skin protection mechanism. It's like taking a pressure point on a bone from a high heel shoe, example in a woman, to a flat-soled shoe. But what was remarkable is this individual recovered from Asia A to Asia C from years 5 to 8, something that's never been reported, nor is there any clinical history from anyone I've ever spoken to that this has occurred in. So using the Asia motor scale, you can see that this individual wasn't able to flick a muscle in the arms or the legs for the first 5 years, and then recovered to about 20% of normal. Well, what does that mean? This simply means that the individual is capable of moving most of their joints in a gravity-free environment. Not really useful, but it's doable. But what was more useful is this type of recovery of sensory function. Again, in the first 5 years, only able to feel in the 2 dermatomes above the level, then recover to about 70% of normal for light touch and 50% of normal for pinprick. And this is continuing. This is important. Now the individual can localize light touch and pain throughout their body. They can tell when they need to shift their weight to avoid skin breakdown. But this is remarkable. In the history of our center and other centers, no one's ever seen this. It's an absolute, and that's why it's important. It just simply demonstrates that a long-term and substantial recovery function is possible as long as we try. So where do we stand now? Well, we're going back and looking at a whole series of individuals who have been doing this similar treatment. So one of the things we started seeing in common with these individuals who had these miracle recoveries of walking is that they were dedicated to activity. That's what led us to begin those animal studies. In combination with those animal studies, it was demonstrating activity could restore their ability to regenerate and recover function. We started seeing this in individuals who were being treated. So we looked at a retrospective study that examined 30 individuals in each group, a cohort study looking at physical integrity, functional restoration, and life advantage outcomes. And basically, this is what we see. This is a normal subject. This is a cross-section through the femur. So this is the thigh bone here. This is the normal muscle of the leg, and this is the fat that all of us have. This is someone with a spinal cord injury. So the overall size of the leg is still the same, but it's replaced largely by fat, and the muscles dramatically reduced. Now this is predictive. This is why people have glucose tolerance problems. This is why people with spinal cord injury develop lipid problems. This can be completely reversed with just 3 months of using this approach. And these are average subjects. I'll show you the data. But again, reversing this muscle mass to normal, decreasing fat to this level, predictably will reduce glucose tolerance as well as hyperlipidemia. These are the kind of data that if we measure using MRI the volume of those muscles, we can measure the volume of fat and the volume of muscle in the subjects that participated in the activity-based program, shown in blue, versus controls that received conventional treatment in a time-dependent fashion. You can see an almost doubling in the reduction of fat in the subjects that received ABR and almost a doubling in the muscle volume. So these are really huge changes. But in addition, we're able to show differences in terms of functional recovery in FIM, primarily in self-care, sphincter control, transfer, but not in other categories where we don't expect to see differences, communication, social cognition, and locomotion. When you look at a change in sensory motor score using an Asia composite score, there is a significant difference between subjects and controls. What's interesting is there's some recovery in subjects. And it's just typically we don't always do careful exams on individuals long after their injury because we don't believe they can recover. But the data is coming out showing that there's spontaneous recovery in most everyone. But the subjects that received the ABR treatment had substantially greater function. Now this all has to be taken with a grain of salt because it's a retrospective study. So what's required at this point, now that we have, I think, some compelling evidence to suggest that we're ready to move forward with a proof of principle experiment, we're ready to do a prospective randomized trial to really do the critical assessment under controlled conditions, whether this activity-based recovery program can enhance function and simultaneously enhance physical integrity, which could then possibly translate into savings and efficacy for reimbursement for this. So it's a randomized, blinded, placebo-controlled trial with 3 arms comparing delivery in the home versus in an institution. It's a collaboration amongst multiple centers, so here at Hopkins, Shepherd Hospital, Shriners Hospital, and Washington University. It's a very large-scale study, and we'll be doing functional MRI and a number of physiology tests in all the individuals to actually get at, can we get some indirect evidence of regeneration in a human being? So we're also just in the beginning of a prospective randomized crossover study in children. This is in collaboration with the Philadelphia Shriners Hospital. So we've already enrolled the first 3 subjects. So in summary, we focused on the problem of spinal cord injury, emphasizing the idea that the approach to regeneration is similar to all these neurologic diseases, independent of the cause of the injury, the importance of crossing the barriers between the clinics and the labs, and that feed forward and feedback. We covered a number of approaches that scientists are taking towards regeneration, ranked them in terms of their doability, and then challenged a number of implicit assumptions in our field. One, that is a substantial and delayed recovery of function possible? Is it possible to strengthen a spastic muscle? Absolutely. Not only can we dramatically increase a muscle, but we can actually use activity to reduce spasticity. We can use activity to be able to take someone off baclofen. And possibly we're not always doing the right thing. We have to be open to the concept that in this new environment where we think regeneration could be possible, that we may be doing things that aren't necessarily good. Likewise, there's things that we may have been doing that could have been affecting regeneration all along, and we simply need to optimize those approaches. So, the real proof of principle needs to be done now. And ultimately, it is the variability, it is the individuals with these problems that teach us the most. And I hope this emphasized the idea that we need to add importance in examining that variability. So I'd just like to thank everybody in my lab who's contributed to this work over the years, including all the collaborators. It's really been a huge effort from a whole group of people, and we've just done a small part. And I'd like to thank those people who take care of these animals 7 days a week, and the tissue culture crew, as well as the clinical group who's carried out most of the clinical treatment and clinical care for these individuals. So I'll stop there and take some questions. Thank you very much.
We might as well ask it. Lots of people are on baclofen. What would these are people who are in many cases, many years out. So what would your recommendation be?
Yeah, my recommendation is this, that one, for example, that case I showed you, that individual was taking low-dose baclofen. Low-dose baclofen does not preclude the ability to recover function, to regenerate. But what I would tell everyone is to work with your doctor to try to slowly get off it, because just as you slowly increased it, typically you can very, very slowly reduce it. And I would ask everyone to get involved in some of the new studies that we're going to be doing. We're moving here, and we're going to be working with Doug in hopefully implementing some of these activity-based approaches and real clinical tests to these approaches. But physical activity and activity is equally critical. But absolutely don't stop your baclofen, and absolutely work with your physician before you contemplate doing anything. And keep in mind, these are early data in animals. But what I can tell you is that most people can get off baclofen slowly.
If you stop it suddenly, he said this, but just to emphasize, you can have seizures. One other question I wanted to ask is, so the animals get better after they've had the FES, the functional stimulation. And you indicated that you thought that was really new neurons being produced in the spinal cord. Why do you think that rather than trophic support, other things, maybe even vascular factors, just augmentation of your spinal cord generator at that level rather than new neurons? Because that's a tougher task, actually, even on your scale of difficulty. Getting new neurons to integrate functionally relevant way at the spinal cord is pretty tall order.
Yeah, I didn't mean to imply that we think that new neurons are born. I just meant to indicate the number of things that activity can influence. Activity can influence differentiation of cells, survival of those cells, elongation of axons from those cells. And the functional role of all of those factors in every study of regeneration is unknown, right? There's not a single study known to man that we know the importance of single element replacement. But I agree that, personally I thought that remyelination was a bigger factor initially, but as time goes on, I believe that that we're pretty naive in believing that element replacement is the major thing that's leading to recovery of function, and that it's other factors, including metalloprotease, the extracellular environment changes, the growth factor delivery, and those sorts of things. In this case, in our experiments, I think we could pretty much exclude metabolic and global things because it selectively occurs only in that zone where that is. But no, yeah, we're far from, in our studies, and as is everyone in this field, from linking any anatomical change to any functional change. And hopefully coming here, we'll be able to do that with the Stem Cell Institute and put those two pieces together and slowly figure it out.
Right. Questions? Mike?
You said that to achieve recovery of function, pattern neural activity is good. Plus pharmaceutical, did I pick that up too? What's the pharmaceutical part of it?
Yeah, you're talking about a reference that I made to building bone density. That normally in individuals who have severe osteoporosis with disorders of immobility, that taking pharmacological agents that prevent bone resorption are capable of slowing down the further progression, but not capable of reversing it. But those pharmacological agents combined with physical activity where there's sufficient load in duration, we're able to restore bone density back into a normal range, like normal physiology. That is, the injured person can respond under normal physiologic conditions to the appropriate thing. But if you do patterned activity with no resistance, you're not going to build muscle mass, you're not going to build bone density. If you ride that bike or try to walk for 5 minutes a day, 3 times a week, you're not going to get these physical benefits. So that was the reference. Ultimately, with this approach, this activity-based approach, we believe it's going to be important as an add-on to any treatment. So imagine the way that we've been doing things. We do a pharmacological intervention or we transplant cells and we put the animals back into an empty cage and let them sit there. It's like the old days of spinal cord injury treatment where we used to leave them in bed for 4 weeks. I don't care how much regeneration they get. If they don't have muscle mass and they can't coordinate those movements again, they're not going to walk. If they go home not walking, they're never going to walk again. So we need to combine these things. And physical integrity is one thing that I believe is important to manifest any functional recovery. So I meant to emphasize this idea that I believe that physical activity in itself can produce magnitudes of regeneration similar to cell transplantation and drug delivery, but that adding it to those treatments that are shown to be beneficial, there should be synergies in terms of adding the physical integrity necessary to manifest the recovery.
John, people will ask you about the bike, the functional electrical stimulation. If they wanted to, could they get it? I mean, is this something which is available or only in the context of a trial?
Yeah, there's 2 companies that currently make an FES bike. There's Urgis and the Stim Master. And we'll be in our center putting bikes in there so people can have access to that locally. We've also been successful at getting these companies to make them and put them in their homes. The downfall of the companies is that it's difficult for them to make these. They're slow, they're a bit outdated, and they're expensive. But there's other ways to do it, particularly if you have incomplete injuries and partial function, where we can work out other things. So both through the center and through prescription, you can get these. And our approach is to train people so that they can do these things at home, and so they don't have to come into the center anymore. And I look forward to doing that with anyone, and encouraging people to get involved in some of the clinical trials.
2 more, and then we've got to move on.
You said that somehow exercise can help reduce spasms. How?
Yes.
Exercise, I get more spasms.
So it depends on how you do it, okay? But the old adage, right, in physical therapy and occupational therapy is exactly right. You should not strengthen a spastic muscle. The idea that why make a muscle that's already spastic stronger? But I can tell you, if done properly, you can dramatically strengthen a muscle, double that muscle size and the force that it can generate, and reduce activity. The goal of our approach is to, you need a sufficient amount of activity. So for example, if you were to only bike for a half hour, that wouldn't have the same effect as an hour. An hour gives you 6,000 equivalent steps. Okay, so for example, if you tried to walk from here to there to back here and back there every day, that wouldn't be enough. You know, you need to do a sufficient amount. So I'd love to. I haven't seen an individual that we haven't been able to reduce spasticity. So we'd love to take on a challenge.
I think we got a bet going on there.
All right.
Last question.
Are you still accepting children for the clinical trials?
Yeah, in fact, we're in the process of transitioning that pediatric clinical trial here to the Kennedy Krieger Institute. So, okay, so by October we'll be ready to enroll subjects here. Subjects can also be enrolled at the Shriner Hospital in Philadelphia. But you can contact us at the Kennedy Krieger Institute, and we can give you more information on that. And/or you can be enrolled as long as they fit the criteria. But thank you so much.
All right, so I know you're probably sick of hearing me talk, but just a little bit more. So I'm going to talk about a couple approaches that we've taken in restoring function to paralyzed animals and where that research has taken us and what it tells us.